Hello, and welcome to Precision Athletic Training Home Study CEUs. I am Megan Hunt, the Vice President of Precision Athletic Training, and I'm happy to have you logged on today. Precision Athletic Training provides quality and convenient athletic training services for sporting events. We were founded in 2009 and began providing CPR and CEU opportunities for athletic trainers in 2013. Please note that the course evaluation form and assessment form are posted on the same page as this video. Please remember to download them, fill them out, and email them to me at mhunt@precisionat.com. When I receive these, I can then email you your statement of credit for the course. If you have any questions, please email me or call me at 781-366-1880 during normal business hours. Our presenter for the Concussion series is Cassandra Johns. Cassie earned her undergraduate athletic training degree at Florida Southern College and her master's in science at Georgia Southern University, focusing on concussion research. Her thesis was focused on the prediction of concussion utilizing baseline assessment tools, which she presented on at NATA in St. Louis in 2015. Along with this, she's also the second author of The Role of a Certified Athletic Trainer/Therapist in Concussion Management, which is published in Current Research Concussion, a Canadian research journal. Without further ado, Cassandra Johns. Hello, and welcome to Precision Athletic Training Home Study CEUs. I am Megan Hunt, the Vice President of Precision Athletic Training, and I'm happy to have you logged on today. Precision Athletic Training provides quality and convenient athletic training services for sporting events. We were founded in 2009 and began providing CPR and CEU opportunities for athletic trainers in 2013. Please note that the course evaluation form and assessment forms are posted on the same page as this video. Please remember to download them, fill them out, and email them to me at mhunt@precisionat.com. Once I receive these, I can then email you your statements of credit for the course. If you have any questions about this, please email me or call me at 781-366-1880 during normal business hours. Our presenter for the Concussion series is Cassandra Johns. Cassie earned her undergraduate athletic training degree at Florida Southern College and her master's in science at Georgia Southern University, focusing on concussion research. Her thesis was focused on the prediction of concussion utilizing baseline assessment tools, which she presented on at NATA in St. Louis in 2015. Along with this, she is also the second author of The Role of a Certified Athletic Trainer/Therapist in Concussion Management, which is published in Current Research Concussion, a Canadian research journal. Without further ado, Cassandra Johns.
Hello, everybody, and thank you for tuning into part 2 of our concussion series, which is going to go into evaluation. As Megan mentioned, my name is Cassandra Johns, and my email is cassie@precisionat.com. So if you have any questions following this presentation and you haven't put them on your course eval that you have to send to Megan, please just email me and let me know, and I'll do my best to answer those questions in a timely fashion. So to start off, let's go into what the 4th International Consensus Statement and the NATA Position Statement recommends for treating and managing a concussion. So we want to start with a multifaceted assessment approach. So this should include a computerized neuropsychological test. I'm most familiar with IMPACT, so that's kind of what we're going to be focusing on when we go into the stats and how it's scored and whatnot. Neurocognitive tests, so again, I'm most familiar with SAC, so that's what we're going to get into. Balance, I've worked the most with Best, so that's what we'll discuss with that as well. Vision, we'll go into a little bit of what the Dynavision does. It's not something that a lot of places have access to, but it's definitely something to be familiar with. And then a graded symptom checklist, which is usually going to be included on your computerized exam. But if you don't have a computerized exam, I know when I was at the junior college, we only had access to SAC, BESS, and a graded symptom checklist for financial reasons. So where that wasn't the ideal way to be baseline testing over 100 athletes by myself, it was one of those things that it was pretty important to do. And at least it gave us more than one factor when we were looking at return to play stuff. And whatever you're using for your baseline should be everything that you would be using in your post-injury assessment. So just kind of keep that in mind as well. So what's the role of your pre-participation examination or your baseline assessment? What are key factors that should be in that? So a detailed concussion history should be a part of your baseline examination or your pre-participation exam. I have a sample PPE questionnaire in this presentation that we can look at later, but I know I've had athletes say, no, I've never sustained a concussion. And when you dug further into the PPE, the questions were, have you sustained a concussion? If so, how many? Have you ever been knocked out? Have you ever blacked out? Have you ever seen stars following a hit to the head? And I would have athletes say, no, I've never sustained a concussion, but yes, I've been hit and lost consciousness. So those are the athletes that when you're going through the pre-participation exam, you want to follow up with them and figure out why they answered no to those questions. You also want to try to identify your high-risk athletes and make sure that while you're doing this, you're educating all of your athletes. So the next slide is going to go through a few education handouts. I like to, when I can, hand the athletes the education form and have them sign off saying that they got it and they read it. So your high-risk athletes might be your athletes with depression, mental health issues, behavioral issues, or any history of concussion. Those are the ones that you want to try to keep a sharper eye on the field if you can think of it, but you should really be watching all of your athletes. But it's just one of those key factors that you should be keeping a sharper eye on your athletes that are at a higher risk. And then it should also include all previous head, neck, face, and spinal injuries. This is important because if they had a facial fracture, the concussion might have been missed because everybody was more focused on the fracture and they wouldn't have been participating anyway with the fracture. So those are kind of things that you want to keep an eye on as well when they say that they've had these injuries on their PPE. Call your athlete and just talk to them about it and make sure that you guys are on the same page about what happened in that incident. So this is a sample handout. I'm going to go through this one kind of the most because it highlights what we talked about in the last discussion. So if you didn't tune into part 1, this will give you a little bit of a refresher. You want to know the red flags. So if they lost consciousness and you can't wake them up, if they've been vomiting, if they have slurred speech, if they can't recognize people or places, if their headache is not on the sheet, but if this headache is getting increasingly worse, or these symptoms start to come up, or I had an athlete describe this one day, and it was one of the best descriptions I've ever heard. If the world looks like Van Gogh's Starry Night, you probably want to send them to the ER just to make sure that they don't have a brain bleed. But it's important to also know that this brain bleed is going to be independent of the concussion itself. So also within the concussion, you're going to potentially have an athlete having a headache. They could have seizures, which you would obviously send them to the ER for. They might look really drowsy. They might have balance problems. They might be dizzy. They could have increasing confusion or irritability, loss of consciousness where they can be awakened, but they lost consciousness and should be sent to the ER. Any weakness or numbness in arms or legs, I mean, you're definitely going to send them for something like that. And an unusual behavioral change. They could also be bothered by light or noise. They could have a slowed reaction time, or they could have sleeping problems. Where we might know this, I thought this was a nice handout for parents to have. It's pretty easy to find. One of their sources is from the NATA, so you know that the information's pretty accurate on it. And it tells the athlete and the parents what they need to do once they have it. They need to report their symptoms. They need to get checked out. They need to have plenty of rest. They need to give it time to recover. and that they should slowly return back. And that if they have any concerns, they need to be addressed. They can't just hide those from everybody. So where this one's blurry, and I apologize that it is a little bit blurry, it goes into what helmets do. And we talked about in the last lecture series that helmets aren't necessarily protecting an athlete from a concussion, but they are protecting them from a brain bleed or a fracture. So they are important. They definitely have their roles, but a handout like this could be misleading to a parent thinking that if they have a helmet, their kid might not have a concussion. So what other handouts are out there? There's the handouts that highlight how much concussions cost and how you might be able to prevent a concussion. This is definitely not a sports-related handout, but I have had athletes come back with handouts similar to this from their doctors, so it is something to be relatively familiar with. And then the heads-up concussion handout. A lot of schools are going to be using this. This is something you should be familiar with. It's easily accessible online if you haven't seen it. And I don't know, a lot of high schools are definitely going to be using this. Some colleges are going to be using this, so it's important to be familiar with. This is a kids and concussions handout that I really liked. It has a coach's action plan and a parent's action plan, or like what the parents need to know. It goes through signs and symptoms, questions that should be asked, when they should call 911. I think it's important because a lot of youth sports don't necessarily have us on the sidelines, and where we all probably feel like they should. I mean, I know I feel like they should. They might not be. And this at least gives the athletes some protection, having some sort of an action plan. And I believe this is from a youth hockey group that gives this handout to their parents and players. And then this is one from a children's hospital. It's not from Boston Children's, but it's something very similar to what you might see after an athlete follows up with the doctor that goes into what a concussion is, what the signs and symptoms are, and what happens when the athlete goes back too soon. One of the biggest concerns about an athlete going back too soon is second impact syndrome. It's something every now and then you're going to see it through the media. You're going to see it on the news. A big deal is going to be made about it. It's important to assure both your athletes and their parents that it is a pretty rare thing that happens, but when it does happen, it has a 50% mortality rate. So it's also something that's very serious, and we do want to do whatever we can to prevent it. And then this is the impact handout, and I want to take a second going over this because this is something that coaches and administrators are going to see. And every now and then you're going to have a coach that might have seen this, and it might not line up exactly with your stepwise protocol through the school or your stepwise protocol on what you're comfortable doing. So if you're familiar with this, you can explain why you're doing what you're doing while comparing it to something like this. So it talks about how important educating athletes, parents, coaches, teachers are or is when it comes to concussions. It talks about doing impact for a baseline, how to do the sideline assessment, when you should do the post-injury testing. It says that you should be doing your impact post-injury testing 24 to 72 hours after injury, so not immediately. You'll see a lot of places do the impact test immediately, and that's not even what impact recommends. If they just sustained a concussion, staring at a computer screen is probably not going to make it better. It's probably not going to help their symptoms. We tell them not to stare at a computer screen. So if I have an athlete that's super symptomatic, I'm going to wait closer to that 48 to 72 hour range to do their impact because I don't want to slow down their healing process. And we'll go into what impact recommends a little bit later on the follow-up testing. It goes through that they should be symptom-free at rest and with exertion before they should return to non-contact activity. So that's good. I mean, it's definitely educating athletes and parents the way it should. It goes through a stepwise return to play and a full return to play. And the impact scores should be back to baseline before they return to play. A lot of protocols you'll see, and you'll see it in the sample protocol I'm going to show you a little bit later, is they might not be back to baseline on impact when they start their protocol. And that could be because they aren't ready to retake impact yet as far as the protocol goes for the school or for impact. So just kind of keep an eye on that and know that where they might start the protocol before they're back to baseline, they shouldn't return to play before they're back to baseline when it comes to impact. So what are some age limitations with assessment? I know working with Precision, I work with a wide age group. I'll mostly work with high school students, but I'll also work with college students. I could work with middle school students. Some kids could be young at some of the camps and stuff, so how would I treat a concussion differently with them? The greatest symptom checklist should be modified for anybody 12 or younger. And this is because the language is confusing for them. It makes it hard for them to understand what you're asking, and they might not know how to answer it. There's a child's GAT-3 for ages 5 through 12. So if you know you're going to be working with a younger population, pull that up on your computer, print it out before you go to the site. Make sure you have that so you're giving them the proper exam. They might not have the mental capacity to take the exam that you would give an older athlete before they even have a concussion. So you can't expect them to have that once they've sustained one. Computerized neuropsychological testing is going to change for our younger kids. I don't believe that Impact has one for younger kids yet, but I know when you're taking into account with computerized testing, you should be retesting them relatively often within their time period at school. So whether it's every year or every other year, depending on the age group, those are things that you want to keep an eye on. And you're going to have some age limitations when it comes to return to play as well. So we'll kind of go into that when we go through the protocol. So impact test. Oh, and the protocol's for the next session. I apologize. I keep telling you about the protocol, but I don't think we go into the return to play protocol until part 3 of this series. So when we do go through it, you'll see all of that. So hopefully you're going to tune into that session as well. So impact that we'll be going over is version 2.1. You see all these numbers on the screen of what sensitivity rates and specificity rates are. First, we're going to go through what sensitivity and specificity are in case you're not familiar. Sensitivity is if a test is highly sensitive and the test results in a negative, you can be nearly positive the condition is not present. With specificity, if the test result for a highly specific test is positive, you can be nearly certain that the condition is present. So you'll hear about false positives and false negatives of some concussion testing, and that's where that comes from. So the sensitivity rate for impact ranges from moderate to good. The specificity rate is actually pretty good for impact as well, in the low to high 80s, and that's pretty much across the board through those studies that I have there, and those are not the only studies out there. I just didn't cite every single one. The reliability of it changes when you look at each individual composite. So there's a motor processing speed composite, a reaction time composite, a visual memory composite, and a verbal memory composite. The processing speed composite is the most reliable, and then I listed down the line according to reliability and the rest. So your lowest reliability with impact is your verbal memory composite. The validity of this test is combined into memory and then the reaction time and processing speed in the research. The reaction time and processing speed has great validity, ranging from 0.87 to 0.96. So that's as close to 1 as we can pretty much hope for as far as validity goes. The memory is poor to moderate, ranging only from 0.46 to 0.62. So that's just something to keep in mind. It doesn't discredit the test at all. It's one of the most commonly utilized tests, according to a study published in 2013 by Cassie Kelly down at Georgia Southern. So it's a test you're going to see a lot. It's a highly publicized test. It's just important to recognize the limitations of any test that we're doing in regards to concussions. So let's kind of go through how concussions work, and I'm going to be going, or how impact works, excuse me. I'm going to be going through this slide and the next slide, and they're color-coded, so when we go over the verbal memory composite, it's going to be the same color as it is on this screen. So verbal memory is composed of word memory, symbol match, and the 3 letters test. And if you're not familiar with impact and your athletes are taking it, you should take it yourself just to kind of know what the test is like. So you're going to look at the total percent correct in the scoring, the total correct that was hidden, and then you have a little bit of math down here on how they figure it out, and then the percentage of total letters correct. And then you're going to look at the visual memory composite. So you're going to have the average of the design memory and the X's and O's, and that's in blue. So we're going to look at the blue here where you have the total percent correct in the design memory. And these are all the tests that are part of the design memory. I don't think I went through them in the last one where these are all the tests that are part of the word memory. And then you have the X's and O's where you have the total correct from the memory. Excuse me. For visual motor speed composite, or the processing speed, you're going to be looking at the X's and O's with the interference and the 3 letters average counted correctly. So you're going to have the total correct interference score within the X's and O's, and then the average correct counted correctly for the 3 letters. With the reaction time composite, which is the pink one on this screen, you're going to have the X's and O's, the symbol match, and the color match. So then you're going to see how that fits in within this perfect score sheet. This perfect score sheet was really helpful when I was trying to understand impact and doing my thesis, but it does take a little bit of time to get down. So if it's something that you need access to, then just email me and I'll send you kind of the link to this. I have it saved on my computer from my thesis, and then I can get this slide for you. Or you might have this slide because it's a home study, so you'll have access to this anyway. And then you have the impulse control composite, which is mostly to eliminate error in the scoring of impact. So you have the orange here with the total incorrect interference for the X's and O's, and then you have the color match total commissions. When we talk about the composites of impact, we talk about verbal memory, visual memory, processing speed, and reaction time. You don't hear a lot about impulse control, but impulse control is one of the indicators of an invalid test, so it's just something to look at when you're going through it on how high or low their impulse control composite score was. And I believe I have a sample score sheet on here as well. So what makes an invalid impact test? What should you be looking for that might not be a red flag on the exam? A word memory learning score below 69, a design memory learning that's below 50, an X's and O's total incorrect interference greater than 30. So these are all things that you're looking for that aren't in the immediate score sheet. You have to look into what each test was broken down. A symbol match average correct reaction time that's greater than 1.75, a color match test total correct less than 7, a 3 letters total correct less than 9, or average counted less than 10, or an impulse control composite score greater than 30. So what else are we looking at? The PPE questionnaire that I talked to you about earlier has been researched. When you're looking at the PPE questionnaire, everybody's going to be a little bit different, but they're going to be the same general thing. So they're going to range from a poor to moderate reliability. And this is mostly because you're almost 100% relying on your athletes to be honest about whatever injuries they may have had. And I'm sure we've all had those athletes that were like, oh, I didn't put that on the sheet because I didn't think you needed to know that. I don't think they're necessarily trying to be dishonest all the time, but they're definitely not always aware of what we really need to know about them. So you have the BEST test, which uses an Eric's balance pad, and I'm sure everybody's familiar with that square blue pad. It has a reliability of 0.57 to 0.80, which means it has a poor to moderate reliability. It's inter-rater reliability. So inter-rater is when multiple people are testing it. Ranges from 0.57 to 0.96. So it ranges from poor to pretty good. Its intra-rater reliability, when you're the only person testing it, ranges from 0.60 to 0.98. To kind of go over BEST, and I could go through this later, but we'll go through it right now. One of my classmates did his thesis on the reliability of BEST, and he looked at it in an injured population. So most of the tests on this exam have been done on healthy individuals, which doesn't give us the best idea of how well it's working. So when he did his thesis, he recruited all of us as graduate assistants. He recruited the staff. He recruited any of the athletic trainers in the area that would come in, and then he recruited the rec center athletic trainers who dealt with anybody who got injured at the rec center and all the club sports. And he blinded the athletes. So when all of our athletes were baseline tested and post-injury tested via video. So you could score live and you could score later in case you thought you missed something when you were doing the live score, and partially for the research aspect of things, I had to score over 100 BEST tests for my thesis individually to give it the reliability that it needed for the test. But he blurred out their faces and had them do the BEST test. And we sat there and we scored. And then 2 weeks later, we sat there and we scored the same thing again in a different order. What he found was that the inter-rater reliability was not so good. I don't know the numbers off the top of my head because it's not my study, but the inter-rater reliability was pretty poor. The intra-rater reliability was around, I believe, the 0.8 range. It's getting ready to be published, so you'll be able to read that when it does get published. But he found that the intra-rater reliability was a lot better, which is pretty consistent with the other research. But this test has also been validated against the SOT, which, if you're not familiar with that test, it's a force plate test where the rim moves around you and you have to balance. And then there's the standardized assessment of concussion. So the SAC test, the reliability of this test is kind of poor when it comes to test retest because there's a huge practice effect, which when we go over the sheet, we'll highlight that. The sensitivity is pretty high and the specificity is moderate. And again, the sensitivity is when the test is highly sensitive and it results in a negative, you can be nearly positive that the condition is not present. So if you have somebody who just sustained a concussion and you're doing their first test follow-up and their test score is where it was at baseline, that's a pretty good indicator that if they don't really have any symptoms and their balance is also where it should be, they probably don't have a concussion. And the validity is moderate, so that's kind of what we expect. And again, these are the most commonly utilized tests across the board, according to a 2013 study by Cassie Kelly. So what is a PPE questionnaire? This is kind of what ours looked like. And our questions about if they had gotten knocked out or seen stars were later in the questionnaire, so it wasn't right underneath the concussion to distract them a little bit. But it would ask if they ever suffered a concussion. If yes, how many? If yes, when was your last one? And did the same thing with an ankle injury, a broken bone, or a knee. Now, these injuries come into play when you're looking at the prediction stuff that we were talking about in the last lecture, where you're at a greater risk of lower extremity injury following a concussion. You're at an even greater risk if you've already sustained a lower extremity injury. So those are good things to know when you're getting ready to return somebody to play if you want to try to be proactive in that aspect. So looking at the best test, you're looking at 3 stances done both on firm ground and on an Eric's pad. You're looking at the double feet, so your feet together, your hands on your hips. If the athlete's hands are not on their hips, it counts as an error. So make sure you're having your athlete's stance like that the entire time. Especially like when they're standing on one foot, their knee has to be like this with their foot back. If they have their foot up against their knee and they're balancing in that triangle pose, that's also incorrect. So those are things that we really want to focus on and be aware of. And you have the tandem stance. You're going to find that most athletes aren't going to have any errors in these 2 stances. And they're more likely to have errors in the single leg balance than they are in the tandem when you look at how the research works. You're going to run into scoring deficits pretty much across the board, because people that were taught to score initially, the scoring is different now. You used to count each mistake singly, and now if they make multiple mistakes at once, so if they open their eyes and take their hands off their hips kind of simultaneously, that only counts as 1 mistake, and they have 3 seconds to go back into that stance. And each stance is held for 20 seconds. So those are just things to look at. Videotaping, if you have access to it, is the best, because you can videotape them and then score later. And then you're focusing on timing them and you're not focusing on too many things at once. So you're getting a better idea of what their true score is. So the assessment of concussion, or the SAC form, this is an older form because some of the words go together, and I know we're taught not to have words that combine. You have orange, tiger that combines, and truck and orange could combine. You don't want words that they can associate with each other, but regardless, it's still a good sample form. You're looking at asking them what month it is, what day is it, the day of the week, the year, roughly what time is it. If they started the game at a certain time, they should have a general idea of how long it may have been if they're still pretty oriented. You have their immediate memory and their delayed recall, and you have their concentration. I've found that post-concussion, a lot of athletes have trouble with the digits forwards and backwards, and they also have trouble with the months in reverse order, but they could have anything. Obviously, if you were testing them post-injury, you're not going to have them do the exertional maneuvers. Those are something that you want to make sure they're not displaying when you're testing them for baseline. You probably aren't going to test that immediately post-injury, so just kind of use your judgment and common sense there. You'd want to make sure you're doing some sort of a neurological screening with them and a strength screening, where strength deficits are pretty rare. Sorry, I'm having trouble with that word right now. They are important, so any strength deficit you definitely want to refer. So what could be on a graded symptom checklist? I tried to list them just so it would be easier for you to see. They could have a headache, pressure on the head, neck pain, dizziness, nausea or vomiting. Now, if they have nausea and they're not vomiting, that is not nearly as concerning as if they're vomiting. Because if they're vomiting, you want to be concerned about a brain bleed, and you want to make sure you're sending them to the emergency room. You want to look out for blurred vision, balance problems, sensitivity to light and or noise. If they feel like they're in a fog or slowed down, if they just don't feel right in general, a lot of the times when you're working with a youth population, you'll have them tell you that they just generally do not feel right. And they don't really know how else to describe that. So that's definitely something you want to pry at if they tell you that. They're going to have difficulty concentrating. So you might have a kid who you work with a lot and they are normally pretty good at conversation that can't focus on the conversation with you. They're going to have difficulty remembering, which hopefully the SAC test will pick up. They're going to have low energy or feel fatigued. They could be confused, they could be drowsy, they could have trouble falling asleep, which you're going to find out the next day. They're going to be more emotional potentially than usual. They could be irritable, just sad in general, or nervous or anxious. It's important to note with this that they might only have one or two of these symptoms. And that doesn't mean that if they only have a headache, they don't have a concussion. I don't know who heard about it. I think it was 2 years ago. There was a school in the South that was attributing most concussions to dehydration because they only had a headache and dizziness. Or sometimes they were nauseous with a headache and dizziness. So those are definitely things you want to keep in mind when you're looking at it. Yeah, if they had a slight hitch to the head and their SAC test is normal and their BEST test is normal, but they're reporting a headache and dizziness, they might not have a concussion, but you definitely want to err on the side of caution with that and at least hold them for that day and make sure they get checked by somebody else because the symptoms could come up later. So you don't want to write these off just as dehydration if things like that happen. It can come back and bite you in the butt pretty good. So what other tests are out there? There's a Kindevic test, which I've just started reading up on, so bear with me a little bit as I go through it with you. But it's a very interesting test. I read all of these articles recently. They're all really great articles. If you need any of them, let me know, and I can get you the names to them. The two that are in press, I can't send you, but the other ones I could. It was originally an eye movement exam that measured reaction time, eye movement, and mental clarity. Now it can be administered by parents, coaches, and ATs. So it's huge that a parent or a coach could administer this, especially if you're working with a high school and you don't travel with them. And what if the visiting team doesn't have an athletic trainer? Now if you're concerned about a potential concussion, your coaches can administer this test and get a slight idea on it. And you definitely want to train them to do that, but it's huge that we have a test that they're now approved to be administrators for. It has a high sensitivity but a pretty low specificity. So just because the test is positive doesn't mean that they have a concussion. You're going to see a lot of false positives with this. But if it's negative, it is pretty sensitive, so that's huge. Excuse me. I'm just going to take a drink so I don't keep coughing on you. So you have the demonstration card, test 1, test 2, and test 3. So the purpose of this test is to track the numbers down. So you would say 2, 5, 8, 3, 9, 4, 6, and go in that order. So when you're actually doing the test the first time, they're in straight lines, which is kind of nice where you can just read them 2, 5, 8, 0, 7, 3, 7, 9, 4, 6, and you just read them in those lines. Test 2, you have to make the lines yourself. So you would have to read them 3, 7, 5, 9, 0, 2, 5, 7. And test 3 is even harder where you would read it like 5, 4, 1, 8, 0. And they get kind of jobbled. What you want to do when you're administering this test is time them. So you want to see how long it takes them to complete each test card. And when they sustain a concussion, you can time them again. And if the time's different, then you should be concerned. Unless the time's quicker, then you probably shouldn't be concerned. But the time is slower, you should be considering concussion at that point. And it's also a really easy test to do on the sideline. So that's good to have. So then we have Dynavision, and we'll pop up to the YouTube video. He explains it a little bit in here, so I want you to listen to that.
Developer of this product, the Dynavision D2. It's a eye-hand coordination, dynamic visual skills training device that gives terrific measurement of an athlete's ability to take in visual information, process that information, turn around, and initiate their movement. Great value to any kind of performance in sports. So we have Zach here. He's going to do a run on the unit, 1 minute run, and Zach, just set yourself up. You see that the unit adjusts upward or down, right from an NBA center right down to a wheelchair athlete.
So what I want you to focus on here is how he's doing the test. There's a few different versions of the test that can be done, whether you're using it to test eye tracking, or you're using it for rehab following a concussion, which we'll go into further into the series. It's not in this part. But these are things that you should be familiar with. If you send an athlete to a concussion specialist in the area, they're likely going to have a dynavision, and they're likely going to use it for rehab. So just something to keep in mind before we continue the video.
What he's going to do is concentrate in that central focal area, let his peripheral vision take over. He's going to make decisions to hit the red lights and not hit the green lights that come on occasionally, and he's going to call out the numbers that flash. So he's doing a lot of cognitive processing and combining that with reactive movements. So are you ready, Zach?
So notice here that when he's hitting the lights, he's not moving his head at all. So when they're properly using the dynavision, their eyes are staying on the screen, and they are, like he said, completely relying on their peripheral vision. And this is what the dynavision looks like. So when he was describing it, that big square box on top can be adjusted to fit the height of the athlete, so that this box is pretty much eye level with them, and that they can reach each aspect of it without changing their whole posture. So what else are we looking at with concussions and evaluation? So there's a few clinical domains within concussions. So you have the symptoms. So you have somatic symptoms, cognitive symptoms, and emotional symptoms. So they could be depressed or have behavioral changes for their emotional symptoms. They could have trouble concentrating. They could have headaches. Like, those are all going to fall into individual domains. And that can help you focus if you are rehabbing them, which again we'll go through more in part 3. You know what areas to kind of focus on. You have the physical domain, so any loss of consciousness or post-traumatic amnesia. Any behavioral changes are going to fall into that emotional symptom domain, but they are important to note when you're dealing with that. They might have cognitive impairment, and they could have sleep disturbances, which it's important. It's easy to forget to follow up with your athletes and ask them how they're sleeping. You notice that a lot when somebody's asking questions, that's one of the questions they forget to ask. But it's one of the most important questions, because if they're not sleeping, their brain's not able to rest as much as you want it to. I mean, we know that the brain never 100% rests, but sleeping is pretty much their biggest healing factor. So that's a huge question when you're asking your athletes. If they're only getting 2 to 3 hours of sleep a night, you want to try to figure out why. You might want to consider referring them so they can get help on their sleeping. So those are all things to consider. So what about post-injury? The International Consensus Statement recommends that an athlete follow up with a physician within 24 hours of injury. Now, sometimes that's not possible if they don't want to go to urgent care, but they should definitely be following up within 48 hours. All these results should be compared to baseline, any post-injury results. The graded symptom checklist likely does not have a baseline of 0. So if you have an athlete that does not have a baseline, normal individuals could have a score of up to 7. And that's something to kind of keep in mind. If all of their other tests are returned to normal and symptoms aren't getting worse with light exercise, their baseline might be whatever they're telling you it is. But that's something you definitely want to work with a concussion specialist on as well. You might not want to make that decision yourself, but it's something to keep an eye on. Some athletes might never fall into the normal range, which is why baseline is so important. And some athletes might always be above those normal ranges. So you might have an athlete who has a concussion but didn't have a baseline, and all of their scores are above and beyond, but they could have been above and beyond beforehand, and there's no way to know because they don't have a baseline. So what are the post-injury testing recommendations? So you want to, like we said, test impact within 72 hours, but then you want to test it every 72 hours after that, which is why we say when they return to play, they might not be at baseline for an impact, because they might not be due, or they return to the progression, not actually return to play, but if they start day 1 of the protocol or day 2 of the protocol, they might not just be taking impact because they're not ready to take it again due to the protocol that you have in place. SAC, you should be taking post-injury and every day thereafter until they're back to baseline. Same with BES and King-Devick. Dynavision isn't used across the board for testing quite yet, but it's definitely something that you could use. You just need to look into their recommendations. They're definitely being used more for like a rehab aspect right now. So what else are we looking at post-injury? The majority of concussions, so 80 to 90% of concussions, are going to resolve within a short 7 to 10 day period. However, the recovery time frame may be longer for children and adolescents, and it may be longer based on a case-by-case basis. So that's why we say there's like a miserable minority. It's because it's only 10 to 20% of athletes that aren't recovering within this time frame. So when do we refer them to the ER? If they have repeated vomiting, loss of consciousness lasting longer than 30 seconds, a headache that gets worse over time, changes in their behavior such as irritability, changes in any physical coordination such as stumbling or clumsiness, any confusion or disorientation such as difficulty recognizing people or places, or any slurred speech or other changes in speech. This is directly from the Fourth International Consensus Statement as well as some earlier studies. When else might you refer, which is also, again, from the Fourth International Consensus Statement? If they're having seizures, vision or eye disturbances such as their pupils are bigger than normal or they're unequal sizes, lasting or recurrent dizziness. So they might be dizzy initially, but if the dizziness is subsiding, it's not really all that concerning. Any obvious difficulty with mental function or physical coordination, symptoms that are worsening over time. So again, that worsening headache. I usually describe to my athletes, okay, you're saying your headache is a 4 out of 6 right now. If all of a sudden you feel like you're getting hit by a Mack truck and there's nothing you can do, you need to go to the hospital just to make sure that there's nothing else going on. Any large head bumps or bruises on areas other than the forehead in children, especially infants under 12 months of age. Now, we're probably not going to work with many infants, but you could be the only medical professional there when an infant falls on concrete or whatever the case may be. So it's definitely something to be aware of in case you wind up treating somebody in the stands because you're the only qualified person there to do so. So what else could be looking at post-injury? This is taken from the International Consensus Statement where it goes over symptoms. Duration lasting longer than 10 days, you want to refer for a second time. Signs and symptoms that you might want to refer for. Anything else that kind of falls into that with their frequency of symptoms and their when the last time they had a concussion was. You want to take their age into consideration. You want to take any medications they're on into consideration, their behavior, and then what sport they're playing in. So in summary, you want to look at those baseline tests, those baseline scores. Make sure that you have those baselines. If you're at a place or a location that you don't normally work at and you're covering it per diem, ask the school if they have a baseline. One of the biggest mistakes you can make is not asking. Where they might not have a baseline, at least you asked in case they did. You want to understand the testing limitations at hand. My graduate director used to joke that you could get a concussion and get better balance, and it's not really a joke, but if you look at some of the research, you'll see that their balance improves within 7 to 10 days of sustaining that concussion. It's because you're having them do the balance test every single day. So it's just showing that practice effect that you're seeing. I always talk about, I've talked about using post-injury scores as their new baseline after sustaining a concussion, because when you're looking at SAC and BES, those scores might be higher than they were on their initial baseline. You definitely want to make sure you're recognizing this concussion. So if you're not recognizing it, you can't evaluate it, right? You can't diagnose it, you can't refer. So recognition is huge in the evaluation process. And you want to make sure you're doing a full post-injury assessment. You should never be doing just one exam. Should always be doing a multifaceted approach. Excuse me. I know I try to keep concussion tests in my kit just in case I need them. So if you don't do that, that might be a good idea, especially when you're working per diem stuff. There's a few apps that you can use on your phone too for evaluation. I know the SCAT app's under revision, so you can't download that right now, but there's a few others that you could use if you need to. So I know this is a home study. You might not be able to ask me questions because it's a home study, but if you have any questions, please put them on your evaluation form. Please email me if you need them. Again, my email is Cassie with a K @precisionat.com. Or if you put them on your evaluation form, Megan can get them to me. So thank you for tuning in, and have a great rest of your day or night.